You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for 12/23/2022. This is the bonus end of the year podcast. To give thanks for all your support at the end of the pandemic, I'll offer up this extra week of TWIC. And normally I take 2 weeks off during the holidays. This week I thought I would try something different, a recap of the year. Now, of course, I wrote a recap and it's up on the heart.org Medscape Cardiology webpage, but I'm afraid fewer and fewer people read words anymore. But in case you have read that top 10 of 2022 piece, this episode will include some other studies and some honorable mentions and other comments. Now, before I start, I want to mention that the heart.org Medscape Cardiology also has a two-part end of the year recap from Drs. Bob Harrington and Michael Gibson. You should listen to that because those two are real academics. The first thing is I want to apologize for my voice. I'm recovering from a URI. I would say that 99.9% of my city of Louisville, Kentucky has a URI at this moment. Okay, first thing is meetings. How good it was to have in-person meetings. My gosh, it was so nice to shake hands and hug and speak to each other without a computer delay. Now, I took many lessons from the pandemic, but one is that Zoom for education is horrific. During the pandemic, my granddaughter, who lives next door to us, did something called NTI, non-traditional learning, which is as grand a euphemism as we have in any of medicine, because she learned nearly nothing, and so it goes with Zoom lectures. I will agree to no more virtual talks. I even heard rumors that one big cardiac meeting is going to do away with virtual options next year, and if true, I say good. That said, cardiology meeting organizers are going to have to do something to attract regular doctors. Now, a pre-pandemic trend that was clearly worsened on return from the pandemic is the sparse attendance of regular clinicians. Now, this year, what I saw in most U.S. meetings were three types of attendees: faculty types, youngsters who had presentations, and industry. Now, I hope meeting organizers find a way to bring back regular clinicians who use the meetings to do CME. Now, I know it's not going to be an easy challenge because conference fees, hotels, travel, these are now super expensive. Plus, most cardiologists are employed and their success turns on productivity, and everybody's worried about days away from the office or laboratory. Some things that I think could be done, I really think meetings could be shortened. I mean, for gosh sakes, late-breaking clinical trial sessions could be cut by more than a half. We need better content, better speakers, more debates, and we need to ban PowerPoint slides with too many words, and also completely cut off the mic and slides after the time allotment. No more going over, period. If the content of meetings was good enough, people would come. Otherwise, these meetings will just turn into boondoggles for people in the academy and industry. Okay, let's go to some trials. First, I think the most practice-changing, paradigm-changing trial, most important trial by far was Revived BCIS. Kudos to that entire team. Now, imagine, just close your eyes and imagine for a second that you're in the cath lab. You have a 70-year-old woman. She has an EF of 27%, 3-vessel coronary disease. Every single one of the lesions are amenable to PCI. And before the cath, she had viability studies showing that there were substantial areas of viable myocardium. Well, revived BCIS found that giving this woman medical therapy, simple tablets, if you will, would be as good as PCI of all that disease. Seriously, there were no differences in death or heart failure, all-cause death, or MI, or quality of life, or not even an improvement of ejection fraction over medical therapy with PCI. Stop here and think. If revascularization of such a patient cannot improve outcomes over medicines, to me, this has to be the spark to help us start believing courage and ischemia and the oodles of other studies saying that PCI ought to be reserved mostly for acute plaque rupture and MI. I really don't know how Divaca Pereira and Mark Petrie and others in this trial pulled this off, but it's a trial that ought to be reviewed in every center's journal club. All right, next topic is spin. This podcast is always on the alert for spin. And spin is language or maneuvers that distract from a non-significant primary endpoint. Now, for readers of the medical literature, it's important to recognize this technique. It's often used by proponents of an intervention. Now, the all-time Babe Ruth of Spin Award goes to the RITA 2 trial of PTCA versus medicines. Just Google it. It's in 1997. Results of the primary and then the conclusions. Just read those two. It's the granddaddy. This year, I gave the Spin Award to the GUIDE HF trial of CardioMEMS versus standard care in patients with heart failure with reduced ejection fraction. CardioMEMS-led management versus standard care resulted in a 12% reduction in the primary endpoint that did not reach significance. The p-value wasn't 0.06 or 0.07, it was 0.16. And there were no differences in heart outcomes like CV death. Only heart failure visits were reduced, but not significantly so. But no matter, the authors, many of whom declared financial ties with the company that makes the device, presented a pre-COVID analysis of approximately 2/3 of the patients who had had their follow-up before lockdowns. Now, this was done in consultation with the FDA, and in this post-hoc subgroup analysis, voila, the heart failure visits were reduced enough to eke by with a p-value of 0.05. Now, the authors didn't emphasize that the 1/4 of patients followed during the lockdowns, a time you'd think a wireless device would have done well, that showed no differences in outcomes. FDA has approved a $20,000 device, and now we, like many other hospitals, are implanting it, and we wonder why there are health disparities and high cost of care in the U.S. Okay, next topic is an example of exemplary reporting of science. I love this story. Now, since I've told you about the year's best example of spin, let me follow with this year's most honest reporting of non-significant results. It's really an important contrast. It's also important to see how science should be done and reported. And before I say anything specific about the trial, let's remember the Bayesian priors of science in general. That is, that most things we try don't work. Discovery and breakthroughs are hard. For instance, most drugs don't make it through development. So, having a non-significant primary endpoint ought to be more common. Of course, it isn't common in our world because many cardiology trials are not designed as a true scientific question, but instead they're set up to show that something works. Now, that something is usually a lucrative something. Now, there's much talk about bias within trials or within the conclusions, but always remember, always, the greatest bias comes when trials are designed, especially if industry is involved. This isn't nefarious, it's just the fact. Okay, I've known Dr. Nasir Marouche, now at Tulane University, previously at the University of Utah, for almost a decade. Nasir is generous and kind, and he's a scientist who had the idea that fibrosis in the left atrium would be a driver for atrial fibrillation and an important target for AFib ablation. And he spent years fine-tuning the ability to detect these areas of scar in the left atrium. He did preliminary studies showing their association with AFib and AFib ablation outcomes. But instead of promoting this technique via single-center studies or case reports or eminence, he designed a proper trial called DECAAF 2, wherein patients with AFib would be randomized to a fibrosis-targeted ablation strategy or standard PVI. And they found no differences in the primary outcome of AFib episodes. And patients in the fibrosis-guided group had a higher rate of procedural complications. And in JAMA, their conclusions read, quote, "These findings do not support use of MRI-guided fibrosis ablation for the treatment of persistent AFib." There was no spin. There was no pre-COVID analysis. There was no hedging. I love this story, and it enhanced my already high respect for Professor Marouche. Okay, next topic is a surprise, my surprise of the year. Now, I am almost convinced that screening healthy people to prevent death from one disease helps only the screeners, not the screened. PSA, mammography, colonoscopy, coronary calcium, vascular bundle screening are all techniques which purport to show that detection of early disease leads to treatment of that one disease and prevention of death from that one disease, and then extended survival. Now, anyone who works in the hospital and has their eyes and mind open knows that there are thousands of diseases that can kill you. These diseases happen seemingly at random, and we live or die largely depending on luck. Now, sure, there are ways to improve luck, like not smoking and exercising and not ignoring chest pain for 2 weeks and perhaps living close enough to walk to work. But largely, we live long or we live short due to luck. And we know empirical studies have shown that a survival benefit from screening for any serious disease are quite minimal to none. And that is why this year, the results of DANCAVAS screening trials surprised me. Now, Professor Axel Didriksen is a soft-spoken cardiology professor in Odense, Denmark. His idea was that you can invite people to a very efficient, approximately 40 minutes of cardiovascular screening session after clinic, and then act on this data that you get to reduce overall mortality. Now, this extremely Spartan program included a questionnaire, ABI, CT scan of the chest and abdomen, which only assessed for calcium in the coronaries or aortic size, a rhythm strip that was done during the CT scan, and blood tests for lipids and glucose. Now, of course, you could not do this in the U.S. because the CT would have to be overread by radiologists, and that would make it expensive and unwieldy. But in Denmark, they simply looked for calcium or aneurysms. That is it. And after more than 5 years of follow-up, they found a 5% lower rate of death, survival, in the invited to screening group. Now, the confidence intervals of that hazard ratio range from 0.90 to 1.00. So the conclusion in the New England Journal of Medicine had to read that the screening program did not significantly reduce mortality, but the bulk of that 95% confidence interval was below 1.00. So there was clearly a survival benefit to this program on average. And there were super important points on interpretation. Note that in DANCAVAS, only 2/3 of the invited group had the screening. And they reported their results not in those who actually were screened. They reported results in the group that were invited to screening. Professor Didriksen said that they will eventually analyze the results of those who came for screening, but that's the so-called on-treatment analysis. But the true scientific question is whether a population-based screening for cardiovascular disease would improve survival. Now, you may wonder why the invited to screen group is the proper way to study this question. I mean, how can you benefit from screening if you don't get screened? Well, the answer is that you study the invited to screen group because those who show up for screening are surely different types of people than those who don't, right? They might be healthier or more in tune with their health, or they might walk more or drink less alcohol, whatever. Those factors, the confounders, may be what makes them live longer, not the screening process. It's why we do intention to treat in all trials. Okay, next topic. I love it when scientists put our dogmas to the test. And a dogma is when you discharge a patient with heart failure, there are a blue million things to go over, and one of these is sodium restriction. And too often, I see patients with heart failure beat down with the most draconian dietary restrictions. But you have to remember that a patient's attention is like a bank. You don't want to use up all this attention in the bank on one thing, sodium restriction. So the question regarding advice for sodium restriction in patients with heart failure is a matter of degree. As I wrote, no one tells these patients to eat ham soup and potato chips every day. The question is how strong our sodium restriction should be. And the stronger the restriction, the more educational attention capital that we're going to use up. The International Sodium HF Trial, it compared a modest sodium restriction of less than 1,500 milligrams per day against standard care. And standard care was the regular standard sodium intake restrictions. This was a pragmatic trial, and it reported no significant differences in the primary outcome of cardiac-related hospitalizations or emergency department visits or death. No differences. Now, criticism of this trial was interesting. It's centered on the fact that the control group only took in 2,000 milligrams of sodium versus 1,600 milligrams in the active arm. The average American diet usually entails more than 3,000 milligrams per day. So the thinking goes, if the sodium heart failure intervention was compared to an American diet, it would have been positive. And as I wrote, maybe that is true, but my rebuttal is that trials are what they are, not what you want them to be. We interpret the evidence as it is gathered, and what I take from the sodium HF trial is that we don't need to spend extra capital on severe restrictions. Give the standard recommendations on sodium and move on to the many other important heart failure therapeutics and education that we have to do. Okay, another heart failure topic this year was big. Many days when I open Twitter or my email, I see nudges from heart failure experts pushing for simultaneous initiation and rapid titration of guideline-directed medications for patients with heart failure who've been recently discharged from the hospital. And these experts cite observational data that shows that we working stiff docs are sluggish in getting our patients to full therapy. They then cite similar observational studies finding that this inertia associates with worse outcomes. The results of the strong HF trial gave this speed movement a boost for sure. The trial enrolled about 1,600 patients with acute heart failure from 14 countries. And patients were randomized to this very high-intensity arm that included aggressive up-titration of heart failure medications during 4 visits in the 6 weeks after discharge versus standard care arm. Now, patients in the high-intensity arm had a statistically significant 14% reduction in the primary endpoint of readmissions for heart failure or death. Notably, both all-cause death and CV death were reduced by 16 and 26%, respectively. Now, there were criticisms of strong HF. Some argued that the trial had a weak control arm, and it basically shows that close follow-up and treatment with heart failure meds work, and it can't tell us much about the which titration strategy is best. But I felt pretty strongly about this trial. It showed that if you are very serious about the intensity of follow-up and the use of medications after discharge, outcomes are better. Of course, implementing such a program will require a commitment from health systems. The question is whether health systems have the resources or will to hire enough clinicians to see heart failure patients 4 times in 6 weeks after a discharge. That is a lot and very intense follow-up, but the trial showed that it worked quite well. Okay, finally, There was a big surprise in policy studies, and this really gets to the philosophy of what healthcare can do. In June, JAMA Cardiology published a very interesting paper from the Beth Israel Group in Boston. The first author is Andrew Oseron, and the senior author of this is Rishi Wadera. And they looked at how insurance coverage in the U.S. affected healthcare access and cardiovascular risk factor management for working age adults who had low income. Now, in the U.S., we have issues with covering the cost of healthcare. Healthcare insurance most often stems from employment by a big company. And if you are self-employed, though, or you work for a small company, you have to buy insurance privately, and it's very expensive, and people often have difficulty and are underinsured or sometimes not insured. But if you are sufficiently poor, you may qualify for government-funded insurance called Medicaid. Now, Medicaid isn't great, but it does grant those with low or no income access to basic health care. And what is clear is this, that there are observational data showing an association with being underinsured or not insured and having worse outcomes. So we have this debate in our country about how much Medicaid should be offered. And then some states decided to expand Medicaid while other states did not. And this created the makings of a beautiful natural experiment. And the study from BI correlated outcomes based on the exposure of Medicaid expansion or not. And the main outcomes they looked at were healthcare access and monitoring and treatment of cardiovascular risk factors. They had 28 million working age adults in their trial. About a third of these were in non-expansion states and 2/3 were in expansion states. So they had two groups there. And if you were a low-income working age adult in a non-expansion state, you had a lower rate of insurance, you were less likely to have a regular doctor, you were less likely to have a recent exam, and you were more likely to have deferred care because of cost. Now, all of those things seem super bad, right? Because you're supposed to have basic health care. The outcome of this study was the treatment of cardiovascular risk factors, and that's, of course, an important thing. But, get this, the group from BI found that there were no significant differences in cardiovascular risk management between these groups. In this study, working age adults with low income in Medicaid non-expansion states experienced higher uninsurance rates, worse access to care than did those in expansion states. However, their cardiovascular risk management was similar. Now, I love this study because it highlights an important concept, one that I've learned from an economist of all people, Robin Hanson at George Mason University. And you know, it turns out that this study is not an outlier. There have been 3 major studies that have all found that more health insurance leads to more health care consumption, but no appreciable effect on healthcare outcomes. First was the RAND Health Insurance Experiment. 7,700 people, 6 U.S. cities, patients were randomized to either free or not free health care. And the group given free health care consumed 30 to 40% more services, but did not have better outcomes in most metrics. A few years later came the Oregon Health Insurance Experiment. Same story. Oregon assigned a limited number of available Medicaid slots by lottery. Those who won the lottery and got Medicaid had substantially and significantly better self-reported health, but there was no statistically significant effect on measures of blood pressure, cholesterol, blood sugar, and more insurance did not reduce the predicted risk of a cardiovascular event within 10 years and did not significantly change the probability that a person was a smoker or obese. And of course, a third study was a study from India. This sample included more than 10,000 households in 435 villages in India. They found that an opportunity to purchase insurance led to a 60% uptake, and access to free insurance led to a 78% uptake, but across a range of health measures, there was no significant impacts on health. Now, clearly the evidence shows that having health insurance leads to more access to care, but on average, this does not lead to better outcomes. Now, how could this be? It's weird. My theory is that those who are uninsured and very sick get major things cared for. I don't know about other countries, but here in the U.S., if you show up with a heart attack, a stroke, major trauma, you get good care regardless of insurance. What is missed with under or non-insured care is preventive care. Now, perhaps these sort of studies aren't detailed enough to show differences in outcomes. They're not perfect studies, but I really wonder whether basic health outcomes don't depend on so much on what we offer in healthcare. Perhaps basic health outcomes, say not dying of early heart disease or not dying of cancer or lung disease, has more to do with societal factors. That is, if you live in a community where the norm is to smoke or not exercise or not go to learn a trade or go to a college degree, it is these factors that may lead to higher rates of disease. Maybe it is not so much access to health care. Now, of course, I'm not arguing that people shouldn't have access. I'm merely suggesting that we consider the possibility that what we offer in non-urgent conditions or asymptomatic people may be marginal. The public health implications here is that policy and monies might be better spent on trying to improve societal outcomes rather than medical solutions. Building parks and biking trails instead of colonoscopy centers and cath labs might be wiser. My bias is that this empirical evidence, with all its limitations, suggests that we shine most when we care for people who are asking for our help. And that, my friends, is why my favorite thing to do in medicine has now become a pacemaker for complete heart block. It used to be banal and boring compared to a complex ablation, but now I've come to appreciate the purity of fixing a fixable problem. So that's it for this week in cardiology. We're going to take a break next week and return the first Friday after the New Year's. I appreciate all the support, really I do, and perhaps a holiday gift that you could give back to TWIC is to go to the app, give us a rating, write us a brief review, as these things really help others find us. So until next year, 2023, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.